Hello, everyone, and welcome to the CoROM podcast. This is where academic medicine meets remote, austere, and resource-limited areas. Welcome back to the program. This is Aebhric O'Kelly. This week, we are joined by Dmytro Vosnyak, who is currently completing his clinical placements in Kilimanjaro, Tanzania, for his second year as a remote paramedic student with the college. Dmytro, welcome to the program.
Thank you for the invitation, Aebhric. It's a real honor to be a guest.
Tell us about yourself and what's keeping you busy.
So I'm a remote paramedic and a combat medic. Now, actually, in my third, not second year of BSc remote paramedic practice program with CoROM. My background includes 5 years as a paramedic on a peacekeeping mission in Central West Africa. And now for over a year, I've been working as a paramedic in a civilian humanitarian project based in Sub-Saharan Africa. And it's been a week now that I'm waking up with the sound of birds singing in Tanzania and watching Mount Kilimanjaro on my way to EMD and back to doctor's compound.
And this is your third time there.
Yeah, that's correct. This is actually my fifth time that I'm in Tanzania. 2 previous times I've been here with some kind of business doing the training. And now this is my third clinical placement to KCMC EMD department.
So, Dmytro, tell us about yourself, where you come from, and what made you decide to do our bachelor's program.
So I live in Georgia, and as I told you before, I already have some kind of medical experience. When I came first to the BSc program, I had already 5 years of medical experience, but I've been extremely fortunate that my academic trainings runs alongside my medical work in the most remote and resources limited settings. Of course, it may sound really obvious, but studying and practicing in a tandem was, and actually it is, a huge advantage for myself. The practice and the theoretical study on the BSc program reinforce each other perfectly. When I began the program, as I told, I had 5 years but a medical experience, but yet every time I start a new module, I discover plenty of material with practical application. Often I reflect on past cases and think with what I learned, I would now approach some of those cases definitely on a different way. My first time that I had face-to-face training with CoROM team was during the Malta training with Team Patrick, Bobby, and Laszlo. And I would like to use this opportunity and also express my gratitude to them again for such excellent training. And by the way, I had previously met Patrick before on an African medevac project. He was on air medevac evacuation team, and and that was a huge surprise for me. I was really happy to see him there. And I was a field medic, so we crossed our paths from time to time there on the duty station at gym or for some kind of rest there, and sometimes I could see Patrick flying there on a helicopter and I handed over the patient to Patrick. So that was really nice to see that my instructor was the guy with whom I worked before in an African project.
Nice.
Besides a lot of hands-on experience, we also had a theoretical component, and the Starbucks on the corner of the street became something of a fuel pit stop. But what I can say that the way that Team Patrick and Bobby presented the material keep me really fully engaged. And I really like the way how Laszlo introduced us to many improvisation techniques for TCCC and prolonged field care. And actually, we now ourselves run BLS and first aid trainings for non-medics, and I've adapted much of their approach in my own teaching. And of course, despite the busy schedule through those 3 weeks we had in Malta, we still had some time for social life, dinners together, and relaxing at the beach after the classes was also really nice. One of the most memorable days after being informed that I actually passed my exam was when we ran hyper-realistic field scenarios with prolonged field care elements. We set up a remote clinic, improvise its layout, then work on live actors simulating traumatic injuries. And I really love training of that kind. Patients aren't plastic mannequins with a calm voice cover telling you which limb is missing. They scream, they grab your hands. When you apply a tourniquet, it makes you far better prepared for actual cases in the field. That's actually one of the reasons why I like the CoROM program, because all the theoretical knowledge you gain, then you can use on the practice. It's not just a dry theory. Unfortunately, I couldn't attend the in-person sessions for tropical medicine and intensive care last time, but I really do hope that I can make it this autumn, that we discussed with you before. And it will also provide an opportunity to attend Year 3 module on pre-hospital ultrasound. I haven't yet begun the theory part, but I already have Dr. Tom Mallinson's pre-hospital and emergency ultrasound logbook waiting for me at home as a part of my preparation. Yeah, that's what can I say about the CoROM.
It'll be good to see you this autumn, because I will be teaching on the tropical medicine course and the eye care, the intensive care in austere and remote environments, and on the APIS course, the ultrasound. So I'll get to see you as you progress through those modules and see the hands-on work. And it'll be good to see how you use the head knowledge you've been using, the learning, as well as the hands-on in Tanzania, and
Yeah.
to see how you deal with the cat. We might take you out to the range and have a bit of some challenges for you.
That sounds good, but as the remote paramedic I work currently now, planning ahead is really a challenge. One day you are with your family, and the next day you are flying out somewhere unexpected. But I'm really hopeful I'll manage to join you this time.
So now that you've gone through over half of the program, how I like to ask difficult questions such as, how can we improve it? What did we do that you felt we could have been better at in the college?
As we talked before, I really look forward to be present for my, I think the favorite module 203, which is intensive care for remote environments. So after that, I will reply on this question in more details. But for now, because I can compare, because I came to CoROM from another teaching facility, let's say like that, from another school, and I can compare things. And I can say that, yes, there are a lot of theoretical material that you need to go through, and even more, you need to do more research. But the practical sessions you do, it's something really amazing that you can see. For example, during my module 104, which was paramedic practice in Malta, I could really see that we use all the theoretical parts on the ground and really work with patients, so that I can say what I like in CoROM, how you can improve. I see, and definitely about that there are some links missing, that you follow them during the program. You try to open the video and you can't open the video, but generally I'm fully satisfied with the program.
So how did you hear about CoROM, and what made you choose our bachelor's remote paramedic?
When I've been working in Africa, in a peacekeeping mission, we had 4 medics in a team. In that time, 2 of them already been CoROM students. So I saw the guys on the level much higher than I was in that period of time. And of course, I asked them, guys, where did you study? Where did you learn? Where did you get all those skills? And they told me that we studied in a CoROM, and I was like, I never heard about the CoROM before. I studied before in Denmark, so I was surprised about that. All right. And the program I was before was just a year program. So, but I really felt that a year program for a paramedic wasn't enough. Even a CoROM program first year, it's mostly about the anatomy, pathophysiology, and then a lot of about trauma, ACLS, pediatric trauma life support, pediatric advanced life support, international trauma life support. So it mostly, from my point of view, about the trauma. So I knew that, and then I read the description of the 3 years, and I decided to do all 3 years, and to get a bachelor degree. And now definitely I can say I did a proper decision. That was absolutely right.
So it sounds like you've done your research. You've looked at two different alternatives, and you like where you're going.
Yeah, that's correct. Yeah, definitely, because I still sometimes meet the paramedics who did the program of 1 year from my previous school. I don't want to say, something bad about the school. Everything was fine, but I really feel that for a real paramedic, the year is not enough. And again, the clinical placement, 3 years, 175 hours each time, is absolutely perfect. And I know that I need these 375 hours each time. And I remember myself after my first clinical placement, after the second, and now I'm currently on my third clinical placement. And I can say that now I have much more skills and I'm much more confident in things what I do. And I know the protocols on better way. And I know that I approach the patients much more confident. Yeah. And also simultaneously, I work separate as a paramedic. So I can assess myself as well as a healthcare provider and say what is better now and why I'm better than I was before.
So it's great to hear you mention the difference between a 1 year program and a 3 year program. What we did when we sat down and we designed this, we looked at the Americans, and they do a 1 year program, and they're a paramedic at the end of it, and they're good. I mean, they can RSI, they can do all the advanced skills. But then we were looking at the bachelor's level, and we just found that it fills in a lot of the gaps. It's after the first year of our program, you are technically a paramedic, and you can get jobs as you're getting a job after 1 year program. But then going through the years 2 and 3 whilst you're working, it gives you a really good chance to apply the theoretical knowledge that you're learning in years 2 and 3.
Yeah, exactly. Yeah, but even now I'm really close to my dissertation. I already thought about what I'm going to describe in the dissertation, and I decided that most likely I will describe my experience as a paramedic in a very remote clinic, and I want to compare the theory material and the practical skills which I get from the college each year to my job and responsibilities. And I really can say that 1 year on my current position wasn't definitely enough to be really fully operational and to respond on the high level to those challenges which I had during this period of time in my clinic. But now I know that all the cases which we had, I knew what I'm going to do, and I was confident that we're going to solve this issue, we're going to treat this patient. Yeah, so 3 years, in my point of view, is absolutely essential for the paramedic.
So at the moment, you're at Kilimanjaro Christian Medical Center. Let's chat about that. So this is your third time in at KCMC, and
Yeah.
can you tell us a bit about your experience?
All right. So I've been in Tanzania now for a week, a bit more. My only chance to do this and other clinical placements is during my leave. So actually, I flew out immediately after my last duty. This is my third clinical placement. The last time I left Tanzania was in April this year. But honestly, I feels like I never left and I've been here for ages. Of course, yeah, of course, it was really nice to be picked up from the airport as always by Johnny. Johnny is always on time, brought me up as always to the weather, general security, news from doctor's compound and KCMC. And I'm really sure that one good local contact such as Johnny is very much needed in this region. And Johnny is the right person. It was, again, wonderful to rejoin with the EMD team and say, I'm back. As always, everyone is extremely friendly here in EMD, and I'm extremely grateful. And I keep in touch with some of the docs and nurses even when I'm not here. I sometimes seek their advice when I want a more experienced opinion on critical care. But in general, Tanzanian people are extremely friendly and down to earth. I enjoy that here you can meet students and practicing clinicians and volunteers from all over the world with absolutely varied backgrounds and experience, and everyone welcome to share that experience. But from other side, the natural beauty, exotic fruits, and occasionally view of Kilimanjaro from your window room or on the way to work, if clouds of course allow you, makes it ideally suitable for me. The first time I stepped into KCMC emergency medicine department, I felt it extremely chaotic. I couldn't really understand what actually the plan of action. They have three sections: pediatric, trauma, and everything else. They have three teams on the ground: doctors and nurses, plus students. And I couldn't find who triaged the patients, who led treatment plans, where to find kit or consumables, where was the lab, X-ray, CT, or ultrasound. And everyone seemed to me be running around transporting patients who just kept coming. And of course, when you first look at that, even if you are from a medical background and have some experience, you wonder what on earth is going on. But now I know the answer to all those questions, and the EMD looks more organized to me, I can say like that.
So talk about your first day. Like you said, it was just absolute chaos, unorganized. And
Yeah.
what was it that got you comfortable in that environment?
Yeah, as I mentioned, the Tanzanians in general, they're really very friendly. I had varied experience and background with different teams, medical and military, and all the teams, they were very different. And let's say acclimatization in each team is also different. And it takes some time for you to understand who is who, what is the protocol, who is the leader, whom to follow. In EMD, the first day when I came, they introduced myself to all the team. They asked me about my background, my capabilities, what is my goal here in EMD, what I'm going to achieve. So I explained them who am I, that I'm here not only to study, to learn, I'm also here to help them treating the patients. And I take the treatment of the patients really very serious. It's not just for me. And you can believe that I will not vanish in the mid-treatment for just cup of tea, and I'll be with you until the end. So that was very nice. And after I start, it was, yes, it was really chaotic. But for me, when it's chaotic, I don't know what exactly I have to do, because no one tell you what exactly the list of your responsibilities there in EMD. I start from the simple things. I start with assessment the patients, taking the vital signs, and then presenting to the doctor. And then day to day, you see new faces, you meet new doctors, you discuss with them. And when they see your capabilities, when they see that you take the treatment of the patients very serious, uh, they 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 believe you, they know that you're confident, so they let you do more interventions. And now I can say that on the third year, I meet the patients on the triage area, I do initial assessment, I even make the decision on the triage about that we are going to take the patients inside the EMD, then I move the patients in EMD, do the secondary assessment, present the patient to the doctor, we together discuss the treatment plan, and then I do all the interventions if they allowed me to do, because, for example, intubation not always allowed in EMD, but sometimes you also can do that. But all the rest, I'm in nursing care, administering medications, rest of the interventions, you can do everything here unless you know how to do that. Sometimes, yes, if you never did that before, you can ask that, can you please show me how to do that? And I never heard that someone told me, no, we can't. But yeah, but normally, I arrive in the morning, I chat with each team member for a minute and say, today I'm your extra pair of hands, just call me. and I know they will call. And my go-to question on shift is, tell me, how can I help you? And that keeps me really fully involved in EMD KCMC.
Your last rotation there in April, you had a mass casualty incident. Can you tell us about that? Tell us how it went and what happened.
Yeah. So at KCMC, most of trauma cases are road traffic collisions, and occasionally mass casualty incidents occurs. I don't know why, but every time I come for placement, I've been involved in MCI. I just shortly describe the capabilities of EMD just to let people understand what they can do, what they have. So, of course, they have their limitations in staffing, supplies, and equipment. On average, during 12-hour shift, they expect and normally receive around 20 critical patients. They have 3 ventilators, 3 intubation kits, one of each is pediatric, 1 manual defibrillator, 1 ECG, 2 suction machines plus manual suction, 1 point of care ultrasound. They have oxygen from the system plus oxygen cylinders for transporting the patients. They have 2 infusion pumps, 8 patients monitors. Unfortunately, they have no capnography available. Blood takes about 30 to 60 minutes arrive if it's available. X-ray, CT, and ultrasound located in another part of the hospital, and it requires patient transfer. And usually on shift, they have 3 doctors, 6 nurses, along with students. Regarding the last MCI in April, I was with a patient in another department for admission. And then I got a call from a doctor, and he told me that many trauma victims had arrived just now following an RTC, and they needed help. Later, in a couple of minutes, similar calls came in from our CoROM students who already on site, and obviously they called everyone, not just me. I handle a patient, and I reach EMD within, I think, 5 to 7 minutes. And I found that the department in that moment was as full as I ever seen it. Patients with obvious traumas and injuries were everywhere. And I checked the triage area, and even it was overflowing. There was no clear zoning for trauma or general cases. I couldn't find the incident commander. Patients were simply everywhere, many in severe pain. I saw that teams were already formed and they were working on different patients. I couldn't find the doctor who called me, and I approached one of our other department doctors and asked how I could help and who was the incident commander. Unfortunately, he wasn't sure, and obviously he was super busy. So he just told me that I have to join any team that looks like needs extra hand. I joined a team that seemed to me need help. They were struggling to find airway equipment and get IV access. I later found that they were from our KCMC ICU. I offered them my assistance and said that I could find anything that they need because I'm from EMD. We had a polytrauma patient with intra-abdominal bleeding, closed leg fractures, right-sided hemothorax, and severe TBI, obviously unconscious. Because at that moment we had no monitors, they were all in use. We didn't know vital signs, but only on touching him, I could say that by his cold skin and the absence of radial pulse that he was already in shock. I found a spare intubation kit and manual suction device when the mechanical one was unavailable. And I always, in my belt pouch, carry syringes, IV set, pulse oximeter, and other small things which necessary in the beginning of the treatment. Since monitors, they were all in use, I placed the pulse ox on the patient and noted poor saturation and tachycardia. We immediately cannulated him, intubated, set him on the ventilator, administered medications, and really stabilized his hemodynamics, and sent him for CT and took care of other casualties. And also, about the EMD and the cooperation doctors with students. It's an open floor. You never limited and no one prohibit you to say something about the treatment plan. If you are capable, you can develop your own treatment plan and agree that with the doctor. Same is in that case, because we had no in the beginning the blood supply. It was obviously limited because of the mass casualty incidents, and most of the team requested the blood. We start with normal saline and waiting for the blood. And then when we attached the patient to the monitors, and I saw that on the monitor blood pressure systolic was more already than 100. The doctor who was the lead of the team was busy. I just told him, listen, maybe we can stop on 100, it's okay with the normal saline. We already achieved the line which we need. And then when we will get the blood, we will continue with the blood. And he was like, okay, sounds good. Let's do that. What do you think else? And I say, it seems to me that we can also give him tetanus, prophylaxis, and TXA, and then we can move to another patients. So he was absolutely happy with my treatment plan for this patient. I found the tetanus and TXA administered, and then we did another patient with on a pediatric part with severe TBI. And then because non-traumatic patients were coming to KCMC EMD, we work with a patient in respiratory failure from stroke who we had intubated. And finally, we finish on a non-trauma cardiac arrest doing the CPR. And I think we had after a couple of the patients with non-critical conditions which we work with. And yeah, that was my experience. But in a conclusion to that case, I really found that unfortunately Tanzania, they don't have a professional pre-hospital service. They don't have paramedics and they have no communication from the field. You don't know like in this MCI how many patients you are going to receive, when, what is their ETA, in what condition. In such cases, you truly see how vital pre-hospital care and how vital clear communication are. And when I was preparing my clinical placement report and reflecting on that experience, I came to the conclusion that despite all the limitations in resources and staffing, and the work done wasn't perfect, but as usual in the real life, but the end result was really solid and ultimately satisfying to me, and I'm sure to other patients and doctors and a team at all.
Knowing what you know now, Dmytro, what would you have done differently? How would you have prepared yourself, or what equipment should the college be giving our paramedic students that would have helped with that situation?
I always take with me the belt. In this belt, I carry syringes or consumables which you need to have in the beginning of the treatment, plus pulse oximeter. And I talked to the chief of the department before and after, and he told me this is really a good idea because normally when patients arrive to EMD, we have some delay between we start to treat those patients in a critical condition. So I would advise each student who come to EMD, KCMC, to prepare the belt and to have their own consumables, at least in their first days working in EMD, and later it will be replaced by the patients because every time when you use it, you can get it from the patient later. But you just save this critical time on the patient. The second thing I think could be better in this case, in EMD, as I say, they have no capnography for confirmation of ET tube placement. Sometimes you can see how it's vital to have that capnography when someone confirmed by pulse oximeter and the auscultation that the tube is in the right place, but actually it's not. And my advice to everyone that before going to Tanzania, you can read the standard treatment guidelines for Tanzania and find their protocols for EMD. So I would like to know more about that resource before I came for my first clinical placement. In that case, I think the only difference I would love to have in that day that to know who is the incident commander and know more about the mass casualty incident plan, particularly in EMD KCMC, because I didn't know what's the plan exactly. And actually, incident commander was there in place, just I didn't know about that. Yeah, but I think my performance was good enough because I talk after to ICU team, and actually I really keep in touch with those doctors from ICU team. I visited them even this third year of clinical placement. And I asked them in that day what I could do better, and they were fully satisfied about my performance because they were struggling to find equipment. I helped them. I cannulated the patient, not from the first approach. But generally, I was happy about that.
I read your Gibbs reflective practice, and that's the main reason I reached out to you to have a chat, because that was quite an experience for you, and it sounds like you did really well.
I'm sure the team did really well. You know, when even if you're alone and you're doing very well, but the team in general, you have no communication, you don't have a leader, it doesn't look good in the end. But because of the team and everyone listen, everyone, and people can hear everyone, and everyone listen different opinions and discuss about the treatment plans, what we can do better. Because in the end of the story, we do that better for the patient. It's not about who is the smarter person on the scene. It's about how to treat the patient on the best way we can do, which is, I think, and I'm sure, the most important in this case.
Dmytro, now that you're on your third placement at Kilimanjaro, have you been to other clinical wards? Have you been to other places within the hospital?
I work in Africa already 7 years as a medic, so I saw many different hospitals here in Africa in different countries. So let's say I have some understanding how the medical system work here in Africa, and I saw really very poor and really resources limited hospitals here in Africa where they don't have most of the equipment and consumables which we can have here in EMD. So I have something to compare. Unfortunately, I didn't see the hospitals somewhere outside the Africa, and as I know, you guys considering for the future, the first year clinical placement will be somewhere in Europe, and then we move for the second and third year to Africa. Am I right?
Yeah, so we are looking at other options to give you a EU or also in the US for your first year placement, and then doing austere for years 2 and 3.
That sounds really good. Yeah. Because I recently discussed with one of our students, because he's also preparing for his second and third clinical placement. And he asked me, what do I think maybe to find another hospital, because he's been here in EMD. And my honest opinion that you never close just in EMD when you arrive to KCMC. You always can make connections with doctors, like from the story about the mass casualty we just discussed. I met doctors from ICU, which means after that I could go to ICU and work with them and see how ICU works. During my second year clinical placement, I moved patient to the theater, and there I met anesthesiologist. And I talked to anesthesiologist and say, listen, I can help you if you need my help. And she was really happy about that. So I went with anesthesiologist to the theater, helped her to prepare the patient for intubations, for ventilators. So you can work here in KCMC in absolutely different departments, and they have here more than 600 beds, which means there are a lot of jobs in orthopedics, gynecology, on the theater, EMD, ICU, pediatric ICU. You work in EMD, yes, and you attach to EMD, but alongside you transport patients to different departments, and you can go there and also see how things work in different departments. So that's what I like about the KCMC. But I would like to have an opportunity and compare this experience in Tanzania with experience in another countries, like you say, in America, and see another standards of treatment patients in EMD or on the pre-hospital setting.
Yeah, I have seen tons and tons of different hospitals, and all the way throughout sub-Saharan Africa, South Africa, and I have never found a hospital like KCMC that has such a high standard of training and treatment. So A lot of the docs at KCMC will rotate out to the US, to the UK, to here in the EU, and will be board certified. Like Francis has a board certification emergency medicine facility right there at KCMC. So doctors are coming
Wow.
from other countries in Africa to get their
Yeah.
board certification emergency medicine right there at KCMC. So I have not found a better place to learn austere medicine than Kilimanjaro.
Yeah. And people here, they extremely welcome to share that experience. And even the last time when I work alongside with anesthesiologists, she told me that two volunteers, doctors from Netherlands, anesthesiologists, came here to KCMC to teach us how to improve our skills on anesthesiology. And you can join our classes as well. So I went there, met doctors from Netherlands in Tanzania who were doing training for anesthesiologists in Tanzania. So I joined their classes, and they had classes from 6 in the morning until 8, and then from 8 you go to EMD, have rounds, and then you work in EMD till 2 o'clock, have lunch, and then you call anesthesiologist and she tell you, yeah, I have a job in a theater, you can join me, I need your help. So you run there, work alongside with anesthesiologist, and then you finish at 5 o'clock. So from the morning you had classes 2 hours with theoretical knowledge from Netherlands, and then you work in EMD with emergencies, and then you work together with anesthesiologists. That's really nice experience. I don't know any other place where you can do the same.
That's the beauty of a teaching hospital, and that is what I was looking for when I found. Well, 10 years ago, I found KCMC and set us up there.
Yeah. And from other side, when you finish your shift there and you go back and you go to the cafe or another places to meet other students and chat, I feel myself on the year 3, like I grew up in this place. I know everyone on the market, everyone knows me in a cafe. I know a couple of words in Swahili, like Asante sana, Karibu, to say someone, thank you, nice to see you. And yeah, that's really nice. I like Moshi.
Nice. That one of my favorite pubs in the entire world is there, and it's called Kili Wonders Hotel, and it's a rooftop pub that you can go up and you can get a 360 view of the whole area. The
Yeah.
mountain is fantastic, and you can see for 100 kilometers in every direction. If you haven't seen that, Dmytro, it's definitely worth a go.
Aebhric, I'm local here. Of course, I've been there, and not only
Ah,
there. And that, yeah, and that that place is really fantastic. You can see Kili sitting on a chair and the view 360 around, and all the Moshi and the territory around the Kili. I like that place as well. And you definitely saw the place inside. I call that like a secret place inside the KCMC when you go on the top of the roof of KCMC, and you also can see the whole. Yeah, I think the
yeah,
picture of our CoROM logo is from that side somewhere,
that is
so you
right.
can see.
I took
Yeah,
that
so
there. Yep, yep.
yes. So that place is also nice. I also sometimes bring their students from the first year to show them, and they're like, "Oh, you know everything about this place." Like, yeah, this is my second or third year. I know everything about this place.
So you finish here in just under a year. What's your next goal? Where do you see yourself in 5 years?
So I'm really quite interested about the program of because for the BSc I left just ultrasound training in Malta and then my dissertation. So I hope next year I will finish everything. And then I feel that I need to improve my skills in critical care and go deeper to the theory part and practical skills. And I found that the CoROM just presented, I can say recently, last year probably, the program in Masters in Critical Care for remote environments. So I'm quite interested in that part. And then I also just recently found on a website that you also guys have a program. I don't remember exactly the name, but it's about the management of the clinic and the improvement of those skills. So I hope to alongside with my work as the healthcare provider to improve my skills in a critical care, and then we'll see.
Nice. Are you thinking about the Masters of Global Health?
Not really. I don't know
All right.
why, but yeah, I'm not interested in a because I discuss with people who has the diploma or master's degree in a global health. It's not something that I'm interested in, and I like to learn material which I work with, and I don't know why I'm interested in a critical care, and I feel that critical care is something that I love. Even in I work in a clinic now and in EMD now. And before I work on a pre-hospital setting, and I have some experience that I can compare the pre-hospital setting and a clinic. And I feel myself absolutely comfortable inside the clinic and on a pre-hospital setting. But I feel that I want to be more confident and know more about the critical care. And that's something that I want to improve. And hopefully you have the program which I want to join and grow as a healthcare provider, which is nice.
I designed the Masters of Austere Critical Care specifically for someone like you, someone who's at the paramedic level that wants to get a deep dive into the concepts of critical care, but in an austere environment, in a limited environment. You have vast experience in this austere environment, so it'll be interesting to see how you go through that master's program and learn some of these advanced skills and how
Yeah.
you will incorporate them into your practice.
And I think you catch really the material which is necessary for paramedics, because every time when I read description of that program, each module specification, it's like, wow, I want to have that. That's exactly what I need. So yeah, I definitely want to have that program after the.
Dmytro, my final question for you is this. What advice do you have for the new paramedic who is just starting out in their career in austere medicine?
I also have the same question from people from the first year, and I always tell them that I know it's not easy to find a job in a medical environment and simultaneously study as a paramedic, but really do your best to find a job as a medic and to study at the same time, because it really makes the material which you study, the theoretical part, much more easier to absorb. And then don't really stop in studying, just study every day, and you will be a better medic.
Nice. Dmytro, it's been a pleasure to have you as a guest. And as an academic, it's so gratifying to see people like you coming through, taking this curriculum that we designed and doing really good things with it. And it is a pleasure to see you take this and run with it and be a better medic than I ever was.
Yeah, thank you, Aebhric, also for invitation. And once and again, thank you, all the instructors from CoROM. You guys make us better medics, and we work on the ground. We help people, so it's a huge impact over the world.
This has been a presentation from the College of Remote and Offshore Medicine. If you would like to earn CPD credits for this podcast, you can join the Council of Members. Being a member of the college gives you free CPD credit, free access to our virtual field guide, and discounts on our e-learning courses. You can join the team on our college website at corom.edu.mt.